So next is Dr. Bhuvan. He's speaking on role of lasers in diabetic retinopathy in the anti-VEGF era.
Thank Dr. Ajay Arora and the whole AIOS team, especially Dr. Lalit, for allowing me to present this. So I'll be presenting the role of the conventional and dual lasers in diabetic retinopathy. The role of laser has really diminished in recent years and it has got very limited indications. I just try to highlight those limited indications because now we have got excellent new treatment options. So I think laser still plays some role, some important role in the management of diabetic eye disease, despite the popularity of anti-VEGF agents. So for decades, we all know that laser photocoagulation was the first line treatment for both proliferative diabetic retinopathy and diabetic macular edema. And after the advent of anti-VEGF agents, which have shown superior visual results and more rapid improvement, the role of lasers have become much more reduced. So just to briefly highlight, so this was the initial times when laser was used, which was on which the treatment was based of high risk proliferative diabetic retinopathy with the guidelines from the DRS study. So they said that if these were the indications, then a PRP laser to be done. But we used to do it even when there was a mild presence of a NVE. Since a worst scenario, I think doing a laser is the best option because the patients are usually lost to follow up. So PDR we all know can lead to severe complication, and hence laser is very important still for the management of PDR, despite anti-VEGF agents and various studies saying that you give monthly injections of anti-VEGF agents, but these are not feasible. And once you stop these treatment, then probably there can be a recurrence of the PDR, which can lead to all these complications of vitreous hemorrhage, atraxial retinal detachment, a combined detachment, or neovascular glaucoma. Hence, PRP still remains the mainstay of treatment for proliferative diabetic retinopathy. How to do a PRP? Very briefly. So usually we need approximately 1600 minimum burns, which is done all over the retina, done over a period of 2 to 3 sittings, and the laser settings would be around 0.2 duration of seconds with a power of more than 200, and they should be separated by half burn. So the main principle is to ablate the ischemic retina. However, with the conventional PDR, there are some disadvantages. That is, it leads to patient discomfort. It can lead to loss of accommodation. It can lead to disturbances in the night vision. If we do aggressive laser, it can lead to a choroidal detachment also. It can lead to exacerbation of the diabetic macular edema. And hence we have to take care of that before, if there is a diabetic macular edema, injecting an anti-VEGF agent. Decreased peripheral vision, color vision, night vision is there, but still PRP remains the gold standard for the management of proliferative diabetic retinopathy. Another new concept is the targeted retinal photocoagulation, which can be done in early stages of severe NPDR or PDR. With the help of wide field angiography, you can locate the areas, the peripheral areas of the ischemia, and a targeted laser can be done. So these will prevent all the complications because of a pan-retinal photocoagulation. But in these cases, a follow-up is very essential, since there may be further ischemia due to the blockage of the microvessels, which can lead to formation of neovascularization. So this is a very interesting concept. Studies have been done. I have tried it, and it's very effective in reducing the VEGF load and also taking care of the macular edema sometimes. So the other are the modern scanning laser photocoagulation techniques, like which we call the Pascal was there, now a simple pattern laser. Other companies have also come forward. It also uses the same 532 wavelength. And in this, we have got patterns, various patterns are available in an arc, a grid, or a bigger rectangle. And that reduces the time and increases the patient comfort since the duration is increased. So, as I said, it reduces the time, increases the patient comfort, and histological studies also show that it leads to less collateral tissue damage to the inner retina due to the longer duration. So, the drawback is, since there is less tissue damage, it also is less effective as compared to a conventional PRP. So, if you're doing a pattern laser, it's very important again to observe these patients, since there may be some presence of ischemic retina, may be presence there may be persistence of the NVE, which requires probably much more intense laser. The other is the Navilas, that is a image guided laser therapies. In that you can, with your all your fundus photograph in your angiography, you can set a pre-guided picture, and with all these, the laser is done by image guided therapy. I have not used it, but this is again new. This is again a new advancement. Again, the role of lasers have reduced, so this is not very popular now, but it's very effective for management of diabetic macular edema. If you've got these images of infrared images, colored photographs, and fluorescent angiography photographs, you can just reproduce them, and the laser is done in an image guided way. So it can be used for both for the management of proliferative diabetic retinopathy as well as DME. So as I said initially also, that in the protocol S, they said you give monthly injections for the management of PDR, but this is not viable either financially or because of the medical constraints in our scenario, because patients are usually ill, they can't come, and if the patient will miss their injections or stop the treatment, it can lead to severe complications. Hence, for PDR, PRP is still the gold standard. Now, coming to diabetic macular edema, we all know that it's one of the most leading cause of legal blindness in diabetic patients. So again, coming to the conventional, as I said for PDR, ETDRS was the one that defined the CSME. Now we basically just use OCT to see these center involving DME, and we have forgotten this term CSME, which I think is very important because there is presence of parafoveal just adjacent to the edema is also present, which has to be treated. So laser definition was done by that. So it prevented the loss of median vision loss by 50%. So the drawback with the lasers in DME is it does not help in the improvement of vision with macular grid, and here anti-VEGF plays an important role. So there is also a risk of vision loss from the central scars which are created because of the laser. The laser gradually expands over time, and these were the limitations over the macular grid, which I think we all have stopped doing after the advent of the anti-VEGF agents. So these are the newer drugs. I am not going into the detail of this. These anti-VEGF agents will be discussed by the other speakers. So these are the new drugs which are now used for DME, and laser, conventional laser, has a very limited role. So protocol T is one study which even Dr. Ajay Arora mentioned, in which showed that aflibercept as well as ranibizumab had very superior response to DME. But why am I highlighting this? Because even in these cases, after 24 to 48 weeks, some patients required focal laser. So focal laser is very important for diabetic macular patients, even in today's scenario. It is like a rescue laser in which you can do a fluorescent angiography later, and wherever there are those focal leakages which are present, those pinpoint red areas, those can be laser. They not only reduce the macular edema, but they will also reduce the number of injections which are required in future. So these newer modalities of lasers, these pattern laser and Navilas, can also be used for the management of DME as for management of PDR also. Selective retinal therapy is another new technique in which the very microsecond pulses of duration of laser is short. It creates a high temperature which is confined to the RP cells only, and hence the collateral damage is very less. So again, this is a newer technique. I have not used it. This is a newer technique, so I just wanted to mention it before I end my presentation. The other is the sub-threshold diode micropulse laser. Dr. Ajay Arora uses frequently. I have not used it, I don't have it. So it is another novel technique which causes very less collateral damage because the near infrared diode laser is confined to the RP layers, and there are microsecond laser pulses which are present that do not cause any collateral damage and help in management of DME. So both these techniques are very similar. They have a very selective role. There is no visible scarring or intraretinal damage there. But however, again, I'm just stressing for DME, the mainstay still the treatment is anti-VEGF agents, and then steroids and probably focal laser as a rescue therapy or to reduce the number of injections. So just to summarize, these are all the laser techniques which can be used for proliferative diabetic retinopathy and DME. The conventional laser was there, the pulse duration which I have just discussed, and all the advantages and limitations I have also discussed. So just to conclude, so laser has now become the second line treatment for center involving DME. However, for parafoveal DME, it's very important. Laser still has a very important role in management of DME, and very important to highlight, it's very important to control the systemic status for management of diabetic macular edema, proliferative diabetic retinopathy. And laser takes some time for its effect to come. So if you're doing a laser, then you should not just hurry for the final results. So when should laser be applied as a primary treatment? When there is a non-center involving DME. If a patient has got a recent stroke or a heart event of less than 2 months, then probably anti-VEGF are contraindicated. And even if the patient has glaucoma and you can't give a steroid, then probably doing a focal laser or a subthreshold laser, I think are often the choice. So the take-home message is the laser is still the gold standard for proliferative diabetic retinopathy. Newer laser patterns are available which are more comfortable. They save time. Anti-VEGF and steroids are the ones are mainstay of treatment for diabetic macular edema, but laser still has a definitive role. And the selective laser therapies, they are the ones which cause less collateral damage and they're not visible, but however the use is very limited. So thank you all for your attention.